Welcome and thank you for joining us for today's SafeScript New South Wales webinar, jointly hosted by Central and Eastern Sydney PHN and Southwestern Sydney PHN. My name is Alex Dolezal and I am the Digital Health Team Leader at Central and Eastern Sydney PHN. Preeti Pandalanini, Health Pathways Coordinator and Pharmacist, is the representative of Southwestern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to any Aboriginal colleagues who might be joining us today. The presenter facilitator for this evening is Mr. Stephen Link. Stephen Link is the clinical analyst, SafeScript New South Wales, and nurse practitioner. Stephen Link is a nurse practitioner in drug and alcohol and a credentialed drug and alcohol nurse with the Drug and Alcohol Nurses of Australasia. He has worked in consultation liaison drug and alcohol for over 25 years and has been involved in the development of combined chronic pain and drug and alcohol clinics. Stephen is an accredited prescriber of medication-assisted treatment for opioid use disorder. Please welcome Stephen.
Thank you, Alex. So thank you again, Alex. So our panel members this evening include Dr. Olatunga, who is a GP at Powell Street Medical in Bankstown. We have Joseph Collegian. Joseph is a pharmacist at Narwee Pharmacy in Southern Sydney. Dr. Candice Warman is a pain specialist and rehabilitation physician in the Illawarra and Sydney areas. Dr. Hester Wilson is a GP and chair of the RACGP's Specific Interest Addiction Medicine Network. Unfortunately, Kim Allgood, our consumer representative, was unable to join us this evening. We feel that Kim's input would have been a vital element to the stories we are hoping to share tonight and would have provided vital context from a person with lived experience of chronic pain. We wish her well from all of our team here and hope that she is able to join us for our next webinar. I would like to acknowledge the traditional owners of the lands on which we meet today and the elders past and present. I acknowledge the ongoing connection that Aboriginal people have to this land and recognise Aboriginal people as the original custodians of this land. I would also like to acknowledge any Aboriginal people who are present here this evening. So the agenda for this evening includes provision of information about SafeScript New South Wales. We will examine the monitored medicines list and introduce you to registration and use of SafeScript New South Wales. We will discuss pop-up notifications and alerts and provide you with a static demonstration using a number of screenshots. We will examine the privacy and legal considerations regarding SafeScript New South Wales and introduce you to implementation support strategies, including education and training, the SafeScript New South Wales clinical advice line, and health pathways. We will then examine a number of case studies and conclude the evening with a question and answer session. The learning outcomes for this evening include how to integrate the SafeScript New South Wales system into clinical workflow processes to improve management of patients using drugs of dependence. Using SafeScript New South Wales to analyse and interpret patient histories to inform best practice patient outcomes. Using current best practice clinical guidance, including best practice communication techniques to manage patients' prescribed monitored medicines and their wellbeing. And how to identify and access critical information and resources to support clinical decision-making and reduce potential harm for patients' prescribed monitored medicines. So what is SafeScript New South Wales? To begin the session, we'd like to take a poll of all of the participants this evening. If people could just put in their answers to the poll. The first question being, I have a high level of knowledge about the real-time prescription monitoring program, SafeScript New South Wales, rolling out in New South Wales. So choose which you feel most strongly represents your view. So you strongly agree, disagree, or strongly disagree. So we'll just take a very brief moment to have panelists or participants type in their response. If we also have, I believe the SafeScript New South Wales system will make it easier for me to manage patients taking high-risk medicines. So the knowledge level, most people disagreed that they had knowledge. There's some who strongly disagreed, and only a few people who agreed or strongly agreed. So that's an excellent response for the purposes of the presentations this evening. If we move on to the next question, I believe the SafeScript New South Wales system will make it easier for me to manage patients taking high-risk medicines. So again, strongly agree, disagree, or strongly disagree. And we'll just take another moment while people respond to that. And the results are in, and again, strongly agree. Most people felt that the system will make it easier for them to manage patients using these medicines. A couple of people disagreed, and there were no people who strongly disagreed within the participant audience. Thank you everyone for that. By way of background, we just thought it would be a good idea to share some information on the increasing harms caused by high-risk medicines. National statistics from the Australian Institute of Health and Welfare show that in 2019, there were 1,865 deaths in Australia determined to be drug-related. Of note is that in 3 out of every 5 of those deaths, opioids were involved, and in 3 out of every 5 opioid-induced deaths, benzodiazepines were also involved. Now, the majority of those deaths were unintentional, they were accidental. In New South Wales in 2018, ambulance officers administered 6 to 7 doses of naloxone daily. 1 in every 1,000 emergency department presentations were due to opioid issues, and most of these were due to oxycodone. Patients were generally aged 35 to 44, and most came from disadvantaged circumstances. And there have been increasing rates of opioid-related deaths in New South Wales over time, with 5.4 deaths per 100,000 in 2018. And so SafeScript New South Wales has been introduced as a part of the New South Wales government's commitment to reducing the harm caused by monitored medicines. SafeScript New South Wales is a digital health system that provides prescribers and pharmacists with access to a patient's prescription history for this group of high-risk medicines, such as opioids and benzodiazepines. Prescribing and dispensing information about monitored medicines is collected via the prescription exchange services and stored in the New South Wales real-time prescription monitoring repository. Prescribers and dispensers using integrated clinical software will receive notifications to warn them when a high-risk situation has been detected. The pharmaceutical regulator within New South Wales Health will have access to the SafeScript New South Wales system and will progressively use the information to adopt proactive regulatory activities. The monitored medicines list within SafeScript New South Wales is shown here. The list essentially includes all Schedule 8 drugs. In addition to Schedule 8 opioids, all Schedule 4 opioids are also monitored. Both Schedule 8 benzodiazepines and Schedule 4 benzodiazepines have been included. In addition, the commonly called Z drugs, zolpidem and zopiclone, the psychostimulants, dexamphetamine, lisdexamphetamine, and methylphenidate, as well as ketamine, pregabalin, and quetiapine have been included. Now, the criteria used to determine whether a medicine should be included in the monitored medicines list was considered by a panel of experts and has included evidence of harm, trends in prescribing, the potential for a substitution effect, among other criteria. Consideration was also given to the approaches of other states and territories in determining their lists of monitored medicines to ensure coordinated approaches and minimise cross-border issues, providing consistency with those other jurisdictions. So please let us know, what is your number one question or concern about SafeScript New South Wales? Now, how do you get started? There is a QR code on the bottom of this screen. If anyone does have access to a mobile device with a QR reader, it may even be possible for you to scan the code whilst I go through the slide, and you may even be registered before we finish this evening's activities. You would have received an email inviting you to register, many of you this week. Once registered, you will need to ensure your clinical software is updated and connected to the SafeScript New South Wales system. Information about how to do this can be found on the SafeScript New South Wales website. Once configured, the SafeScript New South Wales system will operate in the background. When you are prescribing or dispensing a monitored medicine, a pop-up notification will display on your desktop based on information held about the patient in SafeScript New South Wales. SafeScript New South Wales will send green, amber, or red pop-up notifications to your desktop based on information held in the system about the patient you are treating. Green notifications will indicate that in the last 90 days, there are no prescribing or dispensing records for your patient in SafeScript New South Wales, or that your patient has only seen the one prescriber or medical practice. An amber notification will indicate that in the last 90 days, your patient has had prescriptions of monitored medicines from more than one prescriber or medical practice. And red notifications will indicate that in the last 90 days, your patient has had medicines prescribed or dispensed in a higher risk manner, which requires your review. So this next slide shows an example of how a pop-up notification may present, as it may appear in integrated software. Please be aware that for this and for all cases presented tonight, we are not using real patients or clinicians. These are all mock patients and clinicians. So that once registered, logged into the system and using integrated software, a pop-up notification will be sent by SafeScript New South Wales, looking similar to this when you are prescribing or dispensing a monitored medicine. By clicking on the notification, you will be sent to the SafeScript New South Wales site in order to review any alerts generated by SafeScript New South Wales. A red alert will be generated under 3 conditions: high-risk combinations of methadone for pain or of fentanyl when prescribed with a long-acting opioid or with a benzodiazepine or Z drug within a 30-day period will generate a red alert. Please note that this does not include patients prescribed methadone or buprenorphine as a treatment for opioid use disorder. A red alert will also be generated when a patient has received prescriptions for monitored medicines across 4 or more prescribers or medical practices in a 90-day period. Lastly, a red alert will be generated when an opioid dose threshold has been achieved, when the patient has been prescribed or dispensed an average daily dose of opioid of greater than 100 milligrams, which is averaged over a 90-day period. An amber alert will be generated for when a patient has had monitored medicines dispensed to them from 4 or more pharmacies within a 90-day period. And if you would like more information about opioid dose equivalencies, please take a look at the Australian New Zealand College of Anaesthetics Faculty of Pain Medicine Opioid Dose Equivalency Calculator, or the Opioid Calculator app. So we just wanted to take you through a quick mock demonstration of how the system works. Please note what I previously said, that these are not real prescribers or patients. So the first slide takes us back to how a pop-up notification may be displayed in integrated clinical software. By clicking on the notification, you will be taken to the PIN login screen. Once registered and logged into the system using multi-factor authentication, you will be asked to create a daily PIN for ease of access throughout the day, which simultaneously protects patient information from view by other people. This can be the same PIN each day. On entering your PIN, you will be taken directly to the patient's portal. You will notice that the patient portal contains the patient's details for your patient, including the first name of the patient, the last name of the patient, the patient's date of birth, the patient's gender, the IHI for the patient, and the patient's address. You will also see a list of monitored medicines, the practitioners involved in the transactions associated with those medicines, and whether the transaction was a prescribing or dispensing event. To the left of these, any alerts which may have been generated will be displayed and look like this. You can also view the alert history for the patient. And also view the access history of any other practitioner who may have viewed the patient's profile. Now, this can be really important when attempting to coordinate care between multiple practitioners. By clicking on the alert, you can see the details of that alert. In this case, a benzodiazepine in the form of oxazepam has been prescribed for the patient along with methadone for pain, creating a high risk event which requires review by the practitioners involved in the patient's care. When clicking on the alert history, we have an example of this as shown on the screen. Click on the cross at the top right-hand corner to close. And on closing this, we are taken back to the patient portal and the patient details. This final slide for this section shows an example of the view when examining the health practitioner access history. And as I've previously said, this is particularly useful if you're attempting to coordinate care for your patient between multiple practitioners. And again, click on the cross to close. But it's also possible to search for a patient from the dashboard, and this will be most useful for practitioners not using integrated clinical software. So by going directly to the portal, if we enter the patient's name and the patient's date of birth and click search, the patient's details present themselves at the bottom of the screen. You will be able to click on the patient search result to take you to the patient profile directly. It is important to remember that good professional practice involves ensuring that appropriate continuity of care is provided for all patients. Refusing to prescribe medicines to patients who have been taking high-risk medicines over a long period without any consideration for their ongoing care may be unsafe for your patient. For your patient, there are implications to discontinuing some medicines too quickly. And it's important that SafeScript New South Wales users understand that a red or amber notification does not mean that you cannot dispense or prescribe. The alert from SafeScript New South Wales does not instruct you on what to do or whether a medicine should or should not be provided. The decision ultimately remains with you. SafeScript New South Wales will provide additional information and context for you to help inform that decision. But you remain best placed to consult with the patient and to determine whether these medicines remain the safest and best option for them based on their health needs and circumstances. And a number of clinician support tools and resources are also being introduced to assist you to do this. Public hospitals and clinics in New South Wales are not currently integrated with SafeScript New South Wales. This means prescribers and pharmacists need to access patient records using the search function directly from the dashboard in the health practitioner portal we have previously presented. All New South Wales health prescribers and pharmacists will be able to log into the SafeScript New South Wales system using their StaffLink ID and password to view a history of their patients' high-risk medicines prescription or dispensed in the community. However, New South Wales health hospitals and outpatient clinic information systems will not be integrated with the SafeScript New South Wales system at this stage. It's also important to be aware that many of the prescribers and pharmacists registered for or participating in the opioid treatment program in New South Wales are either not using integrated software systems or are not using such systems when recording OTP prescribing and dispensing. This is particularly the case for OTP provided in public and private clinics in New South Wales. This means that the methadone or buprenorphine medicine prescribed and supplied by them to a patient as part of the OTP may not be included in the patient's SafeScript New South Wales patient history. SafeScript New South Wales contains highly sensitive information about a patient's medicine history, and many practitioners and their patients, quite appropriately, are concerned about the security of this information. The information in SafeScript New South Wales is protected under law. Prescribers and pharmacists do not need to obtain patient consent to access SafeScript New South Wales, however. You are only authorised to access the information for the purposes of providing treatment to the individual patient you're seeing. Penalties apply for any unauthorised access. And it's important to be mindful that some patients will experience anxiety about what SafeScript New South Wales means for them. When communicating with these patients, we would encourage respectful and non-judgmental language. To assist practitioners with SafeScript New South Wales, a number of support strategies have been introduced. CPD accredited e-learning modules through NPS MedicineWise are available, covering how and when to use SafeScript New South Wales, information about monitored medicines and clinical practice, and communication and care for patients using monitored medicines. There are PHN facilitated education sessions, such as the one this evening, for both prescribers and pharmacists. There are RACGP and PSA webinars, and some of these are available on the websites of those organisations. Online help is also available through the SafeScript New South Wales portal. A dedicated telephone clinical advice line has also been established to support primary care providers. The service provides direct support to practitioners, both prescribers and pharmacists, when responding to needs of patients who may be at risk of harm. The service facilitates access to clinical advice for addiction medicine, pain management, and mental health, and supports safe de-escalation of high doses of benzodiazepines and opioids. The line promotes a transition to safer prescribing practices, encourages interdisciplinary management, and patient-focused pain self-management skills training where appropriate, and guides appropriate management and referral to other clinical services where required. We also have some enhanced health pathways to support you. The Hunter New England and Central Coast Primary Health Network developed core health pathways for SafeScript New South Wales, which contain key information about the systems and how to use it. Hunter New England Central Coast PHN also developed clinical pathways for GPs and pharmacists, which provide additional support and guidance to manage the patient as a result of an amber or red alert. Sydney, Southeastern Sydney and Southwestern Sydney have been able to adopt this core content into their own health pathways, with some additional information included to reflect local services. The intent is to promote GP-led care wherever practical, supported by appropriate allied health and other specialist services as required. Dr. Martina Gleeson from the Southeastern Sydney Health Pathways team is here tonight to give an overview. Dr. Gleeson, I will hand over to you.
Thanks, Stephen. So just to let you know, these pathways are available on all of the 3 sites that Stephen mentioned, thanks to the work that was done by Hunter New England initially in drafting the pathways. So the SafeScript New South Wales pathway will help you with reminding you what you've learned tonight about how the system works, how it's set up, how to create a SafeScript New South Wales access for yourself, and how to integrate it with your medical software, which is pretty easy. And then the SafeScript New South Wales clinical support for GPs gives you some guidelines on how to manage if you get one of those amber or red alerts and you're not quite sure what to do. And clinical support for pharmacists has similar information. But there's a lot of pathways that are also linked from those clinical support pages that will help you manage a particular problem that the patient may have. So some of the pathways that are linked within our sites include these ones listed: chronic opioid use and deprescribing, amphetamines, benzodiazepines, drug and alcohol advice and treatment services, chronic non-cancer pain and pain management services, substance use disorder, anxiety in adults, depression in adults, mental health services, naloxone for opioid overdose, which is a really important one, and the opioid treatment program. And there's also on some of the pathway sites a motivational interviewing pathway, which can also be helpful. Just if you're not familiar with health pathways and how to find something, we've developed this quick search slide to teach you. If you're in the mobile friendly view, you go up to the top of the pathway and type in the word search that you're looking for. So in this case, it would be SafeScript. And then you choose the relevant pathway that you're looking for. And then if you're looking for something in particular, you can click on the expand all and then use the word command control F and type in a word that you're searching for, and the arrows will help you scroll up and down to find where that term is used in the pathway, which can be helpful when you're looking for something specific like quetiapine, for example. Thank you, Stephen. I think that's my slides. Oh, no, it's not. These are the logins. If you haven't already got a login for your local health pathway team, each of these QR codes will take you to your relevant pathway site, and the usernames and passwords are listed there so that you can get access. And the slides will be shared at the end of the session. So thanks, Stephen.
Thank you, Dr. Gleeson. So this ends the formal presentation for this evening. What we would like to do now is to invite our panel of experts to join me again. Thank you for that. What we would now like to do is just explore several case studies and examine how SafeScript New South Wales may be useful in treating the patients from both a prescriber's perspective and a pharmacist's perspective. So the first patient we have is an inherited patient by the name of Janet. Janet is a 44-year-old lady. She's the patient of a retired colleague from within your practice who has been taking OxyContin for years. Dr. Smythe has prescribed OxyContin for me. You see in the notes she has been prescribed OxyContin 40 milligrams twice a day for the last 6 months. Initially at a lower dose from an emergency department after extensive superficial abdominal burns around 3 years ago. And she attends both to see Dr. Smythe and her pharmacy regularly for her prescriptions. She has no other prescribed medications. She has a prior history of postnatal depression. She doesn't drink, she doesn't smoke, and she has no other major health issues. When you go to prescribe OxyContin for Janet, a pop-up notification appears with a red alert. And the red alert is for a high dose of OMED over 100 milligrams per day on average. So if I could ask our panel members, and I might start with you, Dr. Olatanga, as a GP, how would you proceed with a patient like Janet when she presents to see you?
Thank you very much, Stephen. Someone like this, who is a patient of, say, a colleague of ours who has retired, she's a bit of a challenge in that she's developed a wonderful relationship with her old GP. So as a doctor trying to look after her, the challenge for us is to understand why she's needed these medications. Because our training tells us that OxyContin 40 milligrams twice a day and then seeing the safe alert is quite high, quite dangerous for me as a general practitioner. So I would prefer as a GP, if she was in my rooms, to take a step back and, of course, not offer the prescription, but rather straight away, but to rather get to know her and work out what's been going on. We need to take a bit more of a history. We need to assess these burns and whether she's developed a gradual increased pain threshold to this, or is there something else going on? The other hint you've got, there's a history of postnatal depression. So I'd be thinking about, is there an aspect of long-standing depression, even though they say there's no other health issues. I think as a GP, we should take the time to develop a rapport and get to know what's been going on. So my approach is definitely that one of a therapeutic approach, and try to work out maybe why she's been on so long, examine her, and then work out, could it be something else? Have we missed something that she's required such strong medication? And treat her in a very holistic way, and have an approach that will hopefully bring her back to you. But it's a difficult one. I don't think my overall aim would be to try to reduce, because as you've told us, we can't just stop these medications, but we need to look at ways to safely reduce, or to work out, is there significant other things going on? But that would be my approach.
Thank you, Dr. Olatunga. Joseph, as a pharmacist, Janet brings a prescription for OxyContin to you from Dr. Olatunga. You also received the same notification and the red alert. Can I ask you what your approach would be?
Well, immediately I'd be concerned with the dose. It is quite high. But from the outset, I would be quite empathetic from the start. I think, as you mentioned before, we shouldn't be judgmental. It's difficult to be sometimes, but we've got to do our best. I think, you know, having her been on this medication for such a long time, you know, having had that history of postnatal depression, depression is also an issue with long-term use of opioids. Her pain control long-term with these opioids may actually be worsening. She might have sleep issues, so a lot of issues going there. I'd like to see one prescriber, one pharmacy in a perfect world. But I guess it also provides me with the opportunity to challenge the pain management and make a connection, say with Dr. Olatunga, and initiate a patient-centric approach to the patient's care. If I did end up dispensing this, I would reinforce the risks associated, example, drowsiness and her driving, and whether she was to mix this with alcohol or any other meds, constipation. I guess at the end of it all, I'd just be concerned, long-term use, reduced ability to manage her pain, and just a lessening of the quality of her life.
Thanks, Joseph. I'd like to ask Dr. Wallman. Dr. Wallman, Dr. Olatunga has spoken with Janet, and Janet's agreed to see someone about her pain, and she's been referred to you. Could we ask you for your thoughts on Janet's situation, if we could, please?
I think that the joy of being a specialist is that you get to spend an hour with a new patient and you're appropriately funded for that. So we have issues with all legacy patients that have been on the high doses of opioids. And one of the things that the hour gives us is time to develop a therapeutic relationship. Often we don't try and change things in the first visit. We'll try and develop a relationship and start some motivational interviewing. We need to assess what she's using the opioid for. A lot of patients take it for sleep, and a lot of patients with burns take it for itch. We all really like to assess for mood, and we like to assess for sleep to see if they're a problem as well. And if they are, then if we treat those, often they cope with their pain better if they're well slept and their mood is managed. I like to have a big talk about the adverse effects of opioids. And one of the big ones is opioid hyperalgesia. And a way I like to tell that simply to patients is that we do an experiment with patients who've been on long-term opioids and some that have never taken opioids. And we put their arm in a tub of ice water. And the ones who've been on opioids can leave their arm in for 15 seconds before it's too painful and they need to take it out. And the ones who've never had opioids can last for a minute. So it describes the sensitization that you have due to the opioids. And that's a recent phenomenon that we've discovered. And it's important for them to know that in the short term, they may get some benefit from their opioids, but in the longer term, it leads to harm. The Faculty of Pain Medicine doesn't approve of opioids for non-cancer pain in the long term, and that would be why hyperalgesia is one of the big effects. I also like to touch on the other aspects that are going to be important, like sleep disturbance, mood disturbance, motivation disturbance, osteoporosis, immunosuppression, reduced cognition, and to say that the opioids are impacting on all of these things. And the only real way to reverse that is to reduce the dose in a safe way. And I think that once you've developed a therapeutic relationship with your patient, they will trust you enough to allow you to reduce the dose. But the legacy patients have all just been escalated in dose every time they complain of pain. And we used to think that was the right way of doing things, and we don't think it's the patient's fault, but we need to treat them with something that's more appropriate, like an antineurotic or mood stabilizer or something that's going to help with their sleep.
Thank you, Dr. Warman. I'd just like everyone participating this evening just to take a moment. Unfortunately, as we've previously said, Kim wasn't available, our representative with a lived experience of chronic pain. But if I could just ask all of the participants this evening just to take a moment to have a think about how a patient of Janet may be feeling under these circumstances. She's been prescribed the OxyContin for many years. She's been taking it regularly. She doesn't see it as a problem necessarily. When she's challenged by healthcare professionals in this way, how do we think she might feel? So we'll move on. The next patient is a patient by the name of Murray. He's a new patient. Murray is a 49-year-old man. He's new to the surgery, arriving late on a Friday afternoon as a walk-in. He says, "I know you're busy, doc. I won't take much of your time. I just need a repeat prescription." He's asking for OxyContin, prescribed 60 milligrams twice a day. On checking SafeScript New South Wales, you see the following in Murray's history. Murray is on a fentanyl patch, 25 micrograms. He takes diazepam 5 milligrams 3 times a day, oxazepam 30 milligrams 4 times a day, and he's also taking pregabalin 150 milligrams twice a day. And a pop-up notification appears with concurrent prescribing of high-risk medications, and also a red alert for Murray having more than 4 prescribers at 4 practices in the last 90 days. So if I can ask Dr. Olatunga again, Murray as a patient walking in on a Friday afternoon, as a prescriber, how would you proceed with Murray?
Thanks, Stephen. Aren't they wonderful patients, those ones? They are the bane of our lives. And in real-time general practice, we get a bit worried when we see those patients because it's exactly what they do. They come in, last patient of the day, unbooked, hoping that you will feel pity. So I'm very, very glad that SafeScript have set up an excellent system by which we can now have evidence to tell us what we were thinking anyway about the patient. That my assessments of that, taking in using the SafeScript New South Wales, and that it's that this is a very dangerous patient for being a woman in Southwest Sydney. And so in our practice, what we do is that we make sure we've got security around, because there's 2 ways you can deal with these patients in real time. And that is, one, we can say, no, sorry, we cannot. We have a sign up in our practice which says we do not prescribe narcotics or any sort of SAIDs to first-time presenters to our surgery. And it is a safety precaution which has been set up for many, many years. It developed because we got these sorts of patients. And as a result, we don't in real practice now. But if we were to have one now, and we do because we're a teaching practice, and we get registrars, and unfortunately, somehow these patients seem to know that we have new doctors with training practice. They will come and try them. So I think the system that's been set up is excellent. It's actually will allow us to be able to look at a way. So to be kind and generous, we'll say, look, tell us a bit more about your history. Why are you on this medication? Why are you in our area? And find out a way that we can safely say no to this patient, because you can already see from the evidence that he's already seen 4 prescribers. You'll be the 5th, and he's hoping that you'll give it to him. So my concern as a general practitioner is safety for my practice, and also to be able to deal with it in a very humanitarian way, but in a way that deters them, because unfortunately, once you give one prescription like this, we then find we get more, and usually they're the same. They give us amazing stories. And so I tend to try not to give, and that's why we have signage up in our practice. It's a difficult one. I don't know if we could do the same as what we would have done to the first patient, where we would have tried to develop a therapeutic relationship, because it may not work in this case. And then you've got to deal with an angry patient if you say, no, we cannot, or with our junior doctors say, no, we cannot. So there's lots of issues here. And so I think it needs a bit of a team approach. Most practices, you need to have the discussion in your practices. How are you going to deal with them? How can you deter them? Usually it's a triage thing from the front desk, from the nurse who's on duty. Usually what I tend to do, I come out of my room so I don't see the patient inside the consulting room. This is even more difficult to get them out once they're in your room. But for myself, it's a difficult scenario. And we get one every so often. Some of them are very difficult to deal with, but the things that I worry about for our practice is mainly safety, and to try to reduce the amount of people that request that I would think would be inappropriate, because someone that's on fentanyl, oxazepam, pregabalin, as well as OxyContin, there's a high risk of overdose. There's a high risk of danger to the patient. There's lots of interesting, and we have no real history or rapport to be able to safely try to reduce. And also the other issue is, how are we going to tell this patient we are aware that you're taking other medications? So it opens a big can of worms to try to deal with this sort of patient. So that's our honest opinion. I don't think I could say much else, but one, I wouldn't be prescribing, but I'd also be thinking about the safety of my practice.
Thank you, Dr. Olatunga. Joseph, if I can ask you, Dr. Olatunga, against her better judgment, does decide to prescribe some medicines for Murray, and he presents to you, and of course you will see the same notifications and alerts. How would you proceed from here?
Sorry about that. This does happen, and this is the perfect storm, the perfect Friday storm, which is late Friday, difficulty undoubtedly to contact the GP. This patient has significant risks with the hectic array of polypharmacy that's going on here. Why does this person need so many drugs of this sort? It may be very difficult to try to make them happy, which I can understand. The security aspect is always an issue. And it may be very difficult to foster some sort of caring traction if the person happens to get a little bit testy or is in a rush or is cranky, etc. It's highly complicated. And it's one that, as a pharmacist, is difficult to make a decision on. I guess we've got to explain our obligations as a pharmacist. For me, the other things that come into play are, if I don't know the person and I'm not familiar with the prescriber, not sure in this case study whether I do know Dr. Olatunga or not, that is a problem, because our obligations are that we should at least be aware of the prescriber's handwriting and be familiar with the prescriber, and preferably the patient as well, but it's unlikely. I think I try to have a reasonable conversation, explain that I really do need to be able to contact the doctor, and I'd be happy to do so at the first opportunity I could. I guess I'd contact SafeScript if possible. If I was able to contact the doctor, I may suggest encouraging a staged supply until we could determine a better approach to possible reduction of the dose of this and all the other things in the future. But it's highly complicated. If possible, a long-term collaboration with the prescriber would be awesome, and involving the patient, involving friends and family of the patient. Obviously, all of this would be initiated with the physician in the first instance, and then would try and chime in with that as well. It's a tricky one. Hopefully, I've already closed the shop and they've have to move on.
Thanks, Jason. So once again, I'd like to ask Dr. Warman, as a pain specialist, a specialist in pain medicine, how would you proceed with a patient such as Murray?
Oh, look, I think there's a couple of things. Like, I'm in a privileged position in that specialists don't need to prescribe. And I think that it's very clear that the government regulations only would like one opioid prescriber. And so I can hide behind that and say, I'll write to your GP with my recommendations and suggest, that they follow up with their GP shortly. So that's one answer. When I do get these young men coming in, my favorite hook to try and get them to opioid reduce is to mention testosterone axis reduction. And most young men are very happy to have lots of testosterone and very unhappy to learn that opioids reduce it. And I find that I can very often get them to reduce their dose with the thought that they're going to get more testosterone and feel a bit more vital. I also alert them to the rules that you should only have one opioid prescriber, that's not only for patient safety, but it allows doctors to continue to prescribe, and we can lose our licenses if we're not obeying the quite strict rules. And so I need to say, which GP did you want me to write to? I noticed that I've looked at this SafeScript line, you've had numerous people prescribing, numerous pharmacies dispensing. We need to choose a GP, a pharmacist. Which one do you want to pick? Let's sort out your treatment program. I don't usually touch the psychiatric medications, but I will call the psychiatrists and ask whether, what are they on? Did you prescribe it? What's your plan? Are you going to rationalize it, reduce it, whatever? The pregabalin didn't worry me, but the psychiatric medications did. And so if it's GP managed, I'll talk to the GP and try and sort out what's going on with that. And if it's the psychiatrist, I'll still try and sort out similar. If they have no more medication, I can see that they've been taking it appropriately, regularly. We can't let them withdraw, and we have to organise something to prevent withdrawal. And if that's an emergency, I might give them a prescription for a fentanyl patch with a follow-up appointment with the GP, which has been rung, and I've told them what I've done. But in most cases, I just hide behind that I'm not a prescribing practice. You need to have one prescriber. It's your GP. Pick a GP.
Thank you for that. In this case, I'd also like to ask Dr. Wilson to join the discussion. In addition to Murray's situation, Dr. Wilson, we also have a question from the participants. The question is this kind of patient obviously has major problems and needs care. Where can we send such desperate patients to have their pain and needs attended to when we are notable to help?
Not able to help.
Not able, I think it is.
Yeah.
Thank
Look,
you.
Thanks, Stephen. We need to ask ourselves, what's the diagnosis here? so when I look at this is a young man. He's only nearly 50. He's a young man. He's on 225 oral morphine equivalents. He's on multiple benzodiazepines and also a gabapentin. And as the other panelists have said, we're really concerned around his risk of harm. But the thing that I'm looking at here is, does this young man have addiction, and does he need treatment for his addiction? And that's what we should be thinking. We don't know because we don't have the history, but he is on 225 milligrams of, perhaps he's taking it a day, and he's walking in through our front doors without seeming quite on top of things. So it's very likely that he has tolerance to his opioids. He's also, with his diazepam and oxazepam, it's likely he has tolerance to benzodiazepine. So he has the ICD-11 diagnosis potentially of opioid and benzodiazepine dependence. And on top of that, he's got another sedating medication there that he's taking at a larger dose. So what we need to think about is, how do we treat this young man's dependency? And we're very fortunate with opioid dependency that we have really excellent evidence-based treatments that improve people's outcomes with methadone and buprenorphine. And buprenorphine comes in a number of formulations, including a long-acting. So for Murray, what I would be looking at is really trying to sort out, does he have a dependency? Does he have an opioid use disorder that we can get him to have treatment for, that we can support him to come into treatment for, because we know this will be better? And certainly Candice talking about before about the hyperalgesia, that this could well be going on for him. The low testosterone, this could be an issue for him. When I see this, I think the most likely thing is that this man has a really significant history of past interpersonal trauma. That there are significant mental health issues, there's significant social issues going on for this young man. And we need, and I understand that it is tricky in the general practice setting. I really do. I work as a general practitioner as well. And we do need to look after ourselves. And it's good to have the notes on, on the wall that say, look, we do not give high risk medications to people on their first visit. But it's also looking at how we can have that conversation with him to support him to come and actually seek help for his addiction. It's not always so easy because people don't want to come to see us in drug and alcohol or addiction. He's being prescribed this medication. He's been prescribed it before. He may well have a really significant pain condition that does need management as well. But it's really important to help him to understand the risk and the fact that on top of his pain condition, if he has one, he has developed an opioid dependency, a benzodiazepine dependency, and he needs the correct treatment for that. So to answer the question, he's coming in on a Friday afternoon. Life is unraveling perhaps, and he may well be desperate. And so to be able to point him towards treatment options in your local area through your drug and alcohol services in your local area. And we do have greater access because of the telehealth services that are happening around New South Wales, where drug and alcohol experts, addiction specialists are giving advice into rural regional areas as well, but really trying to encourage him to actually treat what's really going on.
Thank you, Dr. Wilson. And again, I just ask people just to take a moment to think about how Murray may be feeling about his situation. So in responding to a patient like Murray, I guess the first important thing is to actually start the conversation. It's important to discuss the risks of harm, the best outcomes, but also setting boundaries for what you're prepared to offer someone like Murray. Seek advice if you have to. So call the SafeScript New South Wales clinical advice line for advice, and we have the number on the screen here. The health pathways can be particularly useful, and I think Dr. Wilson, you mentioned referral pathways, and the health pathways may be able to assist there. Obtain a second opinion from a GP colleague or a pharmacist colleague, for that matter, if you're dispensing the medicine. In managing and reducing risk and improving outcomes, provide real but very accurate information to your patient. It's important to have a long-term collaborative commitment by everyone involved in the patient's care. So the GP or other prescriber, the patient themselves, the pharmacist, and any other services that may be involved in the patient's care. Having a one prescriber, one pharmacy policy with frequent reviews, checking SafeScript New South Wales routinely each time you see or write a prescription for the patient. Having staged supply of medicines with supervised pharmacy dosing, taking the occasional urine drug screen. Take-home naloxone is really important for patients on particularly high doses of opioids, or when combining opioids with other central nervous system depressant drugs. If you don't have take-home naloxone available at a pharmacy nearby, a prescription for naloxone can be provided. Consider safer injecting technique and advice on that. And if you do have a medically supervised injection centre available, maybe referring to that centre if required. But setting very real but achievable goals for patients, using functional measures like the brief pain index, for example, can be really useful. Consider a tapering plan. And as Dr. Wilson said, is this patient dependent? Do they have an opioid use disorder? And do they require treatment with something like methadone or buprenorphine? Consider safe management and non-medication options for management of their chronic pain. And practice a broad approach for treatment.
And Stephen, sorry, the other thing I do want to say is that there's the 24/7 advice line for Drug and Alcohol Specialist Advisory Service, which is run by the same people that are offering the SafeScript line, but that's specific information about drug and alcohol and addiction. So do just flagging for everybody that that is available as well.
Absolutely, and in a patient such as Murray, where it's not necessarily clear which path to follow, either line will refer you back to the other if they determine that, well, this is more a pain problem or this is more a drug and alcohol substance use disorder problem. And looking at other options, so involving family, friends, community members, if the patient allows. Obviously you do need their consent to do that. Consider non-medical prescribing. Refer the patient for a specialist opinion and consider collaborative management. So use allied health options, pain and/or addiction services. Which brings us to a third patient we'd just like to examine this evening. This is a patient by the name of Abdul. Abdul presents saying, "Hi there, I just need my Tarjan." Abdul is a 60-year-old man. He's well known to you, and he's prescribed Tarjan 15/7.5 milligrams twice a day for severe osteoarthritis to both knees. And hips. He has a past history of recurrent lower back pain and chronic insomnia. He has notifications from SafeScript New South Wales saying that there is a red alert with 4 or more prescribers at 4 or more practices in the last 90 days, and an amber alert for having accessed more than 4 pharmacies in 90 days. So his oral morphine equivalency is 80 milligrams on average per day over a 90-day period. So he doesn't achieve the threshold for a red alert for high dose opioid. In looking at SafeScript New South Wales, you see the following in Abdul's history. He's on endone 5 milligrams as required for breakthrough, taking approximately 60 tablets a month. He takes Panadeine Forte as required, 150 tablets a month. Diazepam 5 milligrams at night and has around 50 tablets a month. Pregabalin 75 milligrams twice a day, 56 tablets a month. And Tarjan 15/7.5 twice a day, and he gets around 56 tablets a month of that as well. So Joseph, if I could bring you back into it, the discussion. As a pharmacist, you will receive the red notification. How would you proceed for someone in Abdul's situation?
Well, I guess the thing that I'd noticed straight away with the alerts is that he's gotten around town a bit to some prescribers and pharmacies. Having known him, I'd hopefully would be able to feel comfortable to be unfazed by this and just start a bit of a conversation and discuss the importance of, sticking with one prescriber who'll be able to follow through with a good treatment regimen, and preferably one pharmacy, but that's up to the person. I think I'd need to sort of understand what he thinks about his pain, what he thinks all of these meds are actually doing for him. There's a lot of medication here, a lot of sedation potentially happening here, and he may have no idea about what these are all doing. And potentially this is a risk of harm, and potentially accidental harm. I definitely want to have a discussion with one of the prescribers if possible, and just see, because I think this cocktail of medications is just a recipe for disaster potentially. It's I'm not necessarily going to be able to get through straight away, because sometimes they just want their medication and be gone. But I want to feel comfortable about having a chat and making this a two-way conversation.
Thanks, Joseph. Dr. Wilson, as a specialist in addiction medicine, how would you proceed in this case of someone like Abdul presenting?
So when you look at Abdul, he is taking his Tajan as it's been prescribed by you. He's taking a little bit of Panadeine Forte. It's not a huge amount. He's taking some diazepam. Once again, it's not a huge amount. Pregabalin, understandable. And I look at that and I think, for prescribers, for practices, he might be getting his diazepam from his psychiatrist. He might be getting the pregabalin from his pain specialist. He might be seeing another GP who's closer to where he works occasionally when the pain's bad. And so there may well be very good reasons why he's seeing a number of different prescribers. As a GP, I work part-time. And so he might be seeing my colleague because I'm not there. So there's some good reasons why he might be turning up with these. So I'm looking at this, I'm not that panicked by it, but what I would be saying to him is, I'm noticing that you're going to different pharmacies and you've got different prescribers, and I wasn't aware of all these medicines that you've been getting. Perhaps, I wasn't aware that you've been getting these medicines from other doctors. I want you to help you to understand why that's a concern. So one of the things for me with SafeScript is when I'm using it in a consult, I will always use it when they're with me. And so I open it up, we have a look together. So it's actually talking them through it. Quite often I'll actually go and have a look beforehand if I think I'm going to need it, because sometimes it can take a little bit to kind of sort through what people are taking, what's dispensed, what's prescribed. But I will always look through it with them and I will say, this is what I'm seeing. And it may well be that Abdul has some really good reasons why he's seeing a number of different pharmacies, prescribers. He may not realize that there's a risk. And so it's really working with him around that risk, and explaining why it's really important that one doctor has an understanding of all the treatments that are going on, because together they could cause him harm. And we really don't want him to have harm. What I'm really interested in is this treatment, is what he's on actually having any benefit? And so I want to actually do an ongoing assessment and review of whether it's actually managing his pain conditions. Why is he on diazepam? Is that for pain? Is it for his insomnia? Is it treating his insomnia? I really want to know if the medications that he's on are actually working. So doing a good assessment, and I do like using assessment tools, things like the Brief Pain Inventory, to really get a sense of how well he's traveling and whether this treatment is effective. And if it isn't, then we need to be thinking, well, maybe we need to change it. And maybe we need some advice from Candice, our friendly pain specialist. Maybe we need to work with our pharmacist, once again, to let's get this all happening in the one pharmacy so that we're clear on what's going on, and working together, as we've all said before, in that long-term therapeutic alliance for the best outcomes for our patients.
Thank you for that. And so, again, if we just take a moment to consider from Abdul's point of view, There may be multiple factors for what Abdul is doing. There may be a lack of awareness of the effects of medication, as Dr. Wilson has already said. He may not be aware of pain management strategies or the dangers of dependence. He may have an awareness of the situation but feel trapped by it. I can't stop these things. When I do, I get crook. He may indeed have an existing substance use disorder, and that does need to be assessed, but he may not. It's important to remember that a substance use disorder is a medical condition and that drug-seeking behaviours can be a symptom of that condition. So things to consider with patients like Abdul are to help the patient recognise what the issue is, work with the patient to set goals for recovery. Again, as I said previously, they need to be real but also achievable for someone. Help the patient to seek the appropriate treatment that they require and consider evidence-based non-pharmacological options and evidence-based pharmacological options for substance use disorders if that is the diagnosis. And consider use of other low-risk medicines. When communicating with patients using monitored medicines, always use respectful and non-stigmatizing language. And you can see the Pain Australia's chronic pain language guidelines or the RACGP, how stigmatizing language affects people in Australia who use tobacco, alcohol, and other drugs. But some very brief tips from motivational interviewing come from the RULE and AWS acronyms. So if we use RULE, so resist the writing reflex, so that tendency for us to advise patients about what the best thing for their health might be. Recognize that most people who are ambivalent about change tend to resist persuasion. Understand the patient's motivations and their reasons for changing. Use those to increase the likelihood of behaviour change as opposed to explaining your opinions about why they should change their behaviour. Listen with empathy. I think empathy takes us a long way with patients. Empathy helps us to understand what actually might work for the patient, but empower the patient by exploring their ideas about how they can make changes to improve their health and draw on their personal knowledge about what has been successful for them previously. And with the AWS, use open-ended questions. Open-ended questions help you to learn more about what the patient cares about, such as their values, their goals. For example, how are you managing at work? Rather than, are you going to work? Use affirmations by making compliments or statements of appreciation and understanding. This can be most effective when the patient's strengths and efforts for change are noticed and affirmed. An example of this could be, I appreciate that it took a lot of courage for you to discuss your medicine use with me today. It supports the patient to continue to talk with you. Use reflective language to help reinforce the desire for change. It rephrases the patient's statements to capture the implicit meaning and feeling. So it sounds like you're beginning to worry about the effects of your medicine on your life. You find your day revolves around the next dose and it's starting to make you think something's not right. And summarize to help ensure mutual understanding of the discussion so far and to help point out discrepancies between the patient's current situation and their future goals. So can I just check in with you that I've understood what we're discussing here? You're worried about your symptoms and the effect they're having on your sleep. That's then affecting your work and you're now anxious your manager might notice. Is that right? And a general rule of thumb with motivational interviewing is to try to ask one open-ended question followed by 2 to 3 reflections. And we just wanted to introduce some references to you this evening. I won't go through them, but they will be in the slide pack that is sent out.
Question about how do we explain to our patients why we're doing this, why we're using SafeScript, and a concern about practice privacy policies.
I can explain
Wilson?
what I do because I've been using SafeScript for quite some time, and I will say that this is a program that's been put together which gives us up-to-date information on all the medications that people are accessing. And it's a good thing because it helps us to understand exactly what's happening and what risk you might be at. That the medications that are on it are medications that can cause people real harm. And I want to ensure that I'm doing the best thing by you to keep you safe. You know, and so I have to say I haven't had an issue with people saying this is a terrible thing, but I have had people kind of asking, well, who has access to this? How is this kept private? And so look, it is only available to pharmacists and prescribers, be them NPs or doctors, and I have to log in every day, and it has this two-part authentication. You know, so it's only the only people who are allowed to can look at it. And every time I go in, it records that I've been there. So it's keeping a bit of an eye on me as well. But it is absolutely, it's a tool to ensure that I'm doing the best possible prescribing and that we're doing the best thing for you to actually ensure that you're not coming to harm. And we're going to work through this together to ensure the best outcomes for you.
Thank you.
Can I just comment as well? Because I only just started. I only registered about 2 days ago. And it's been put on our software and it's been fantastic. Almost every single patient, I didn't know that I prescribed quite a bit, but it sort of brought out what my prescribing traits were. So from a perspective for a GP that's thinking about using it, I'd say go for it. It's very positive, and you'll be surprised because what it shows me just in 2 days, that my patients only go to me for some of these scripts. And that's really reassuring. That's a good thing.
We've had a question come in around, do such patients have an abnormal physiology and metabolism that explains their predicament? And it's got me thinking a little bit about, I know Dr. Warman, you mentioned earlier about testosterone, but it's got me thinking about what other hormonal systems can be affected by the opioid type medicines, and is it worth testing those hormonal systems, and what do they mean? Would you mind answering that for us if you could, please?
I think we might need an endocrinologist for that one. So I am not aware of all of the hormone systems that are affected. I certainly know that sleep regulation is affected and testosterone is affected, and there's immunosuppression. And we find a lot of, I work at St. Vincent's, there's a lot of patients who've had lung transplants, and you can pretty well predict with the higher doses of the opioids, the more trouble they're going to get in with infections, whether it's, you know, pneumonia, whatever, the infection rates go up a lot. So no, I'm afraid I'm not the expert on the hormone regulatory systems.
Thank you.
On the hormones, the other thing that we know with opioids is it does affect fertility. So the female hormones are affected and also increases risk of osteoporosis. Yeah, look, and I think just if we're thinking about the risks that people might have, certainly one of the things that I'm always thinking about is actually their psychology, so their mental health and what's happening there and what have been their past experiences. Have they had past trauma, and is that impacting them? You know, so it's really important to be thinking about that as well. That you know, also looking at the other things that might be going on if they're drinking alcohol, using other sedatives that are not medicines, you know, that those can actually increase the risk. We know the group of people that are at most at risk of overdose are older men who are using polysubstances, and Valium figures really highly in that on its own. It doesn't cause a lot of overdose. It is a risky medication, but mixed in with other things, that it causes significant risk of overdose. And the other thing to remember is that it's not just fatal overdose, it's non-fatal overdose and the cognitive impact that can have on people because they've had a period of hypoxia and it actually affects their brain function, and that can be long-standing.
Thank you, Dr. Wilson. A question has come in, and I might throw it to both Dr. Olatunga and Joseph, if I may. The question is, can we prescribe, but I'm going to include in this, can we dispense only a few tablets if it looks like we're in danger here? Could I ask you both to join me with that question, please?
That's an excellent question. A few years ago, we had a dilemma where our practice is more than 27 years old. and a young woman who's now a middle-aged woman now. And so we've been looking after her, and then she, through all her sad history, became dependent on opioids and benzos. So what we did, because she was our regular patient, and I think she was seeing a pain clinic, we would give her prescriptions of diazepam. And I was so pleased with our registrars at that time. They dispensed prescription of 50, so 7 a week to the appropriate dispenser. And it was very safe, because about a week later, the police were called out to that young person's home, and they were going to, because apparently they thought she'd overdosed. So I happened to be in the area that time, and I had a look, and I quickly checked our notes, because I thought maybe we had done the prescription and she'd overdosed on it. But I was so happy to see that our doctors had strictly prescribed just in segments of a week. So the 50 was given a week, the 50 tablets were given a week at a time. And I'm sure, Joseph, you've had that sort of experience with these sorts of cases. So there are certain cases we have to do that sort of prescription. And so we've set it up now as a very safe way of teaching our young doctors to safely prescribe benzos and even opioids. The only exception might be our palliative care patients, where, because they are terminal, we're going to be incrementing their opioids due to pain management. But no, we definitely do it. And I was very glad that that one opportunity that we did do it and the police were called out, we were not to blame for her overdose. So it was good.
There's a question about, oh, sorry.
I might just, if I could just ask Joseph to give a pharmacist perspective on that, if I could, please.
Yeah, I echo those comments wholeheartedly. So we do have, in my practice, we do have one or two patients that are set up in discussion with the GP in this situation as a stage supply. So they'll come in once a week, and we will provide them with the number of doses that the GP has deemed required. And yeah, it works really well. Because some of these patients are quite fragile and lessen the risk of having a full box of 50 tablets with them, due to their history. So we are happy with that, and they are too, because they're aware that their history might be an issue.
And is that a decision you're able to make if you're concerned for the safety of the patient?
We could. But I think what we would do first is give the physician a call and just say, look, would you be okay with us doing this? There's also the use of Webster packs, of course, but in the stage supply area, yeah, definitely would. If we had any concern whatsoever, and it has happened before, we will definitely recommend this system if possible.
Thank you, Joseph. Dr. Gleeson, you were saying that there's another question coming through.
Yeah, there is. It's a question for Candace, and it says, what is an appropriate use of opioids? Because the opioid pharma companies advised that it was okay to manage pain as long as it kept the patients functional. And the questioner is asking, is this no longer the case?
Oh, look, it's a tricky question. I think that functional tends to be what we're focusing on at the moment. And sometimes we try to encourage that the patients take their opioid before they do some physiotherapy or go for a walk or some exercise, so then they can get rid of the deconditioning effect that's also impacting on their pain. Long-term opioids for chronic pain are pretty well always a bad idea, and we usually try and taper them and try and build up adjuvants, whether they're antinuretics or paracetamol or ibuprofen, whatever's appropriate. And often pain management courses are very helpful with the chronic pain in a way that the opioids aren't, and trying to give them some sort of power over their pain and some other way to reframe it and look at it. And we use that a lot. But yeah, it's tricky with the opioids because patients see it as a silver bullet, you know, a cure, that they take this and their pain goes away. It's not working anymore. Can I have extra doses? It's like, no. Yeah. So it's a tricky thing, but no for long-term pain for opioids from me, whether functional or not. Yeah. And usually once they wean off, they're different people. It's so personality altering in a way that you'll never understand until you've weaned them, and neither will they. And then once you get them off, they'll just be able to cope with their pain. Their pain's pretty well unchanged, whether on it or not. It's just developing enough of a relationship to reassure them and get them off. So, yeah.
Dr. Warman, I might ask you to stay where you are just for a moment, and also ask Dr. Olatunga, a question's come through. What about our many elderly patients with osteoarthritis taking long-term low-dose opiates? Should we target them?
I think that it's nice to add any adjuvants in that you can and try to increase activity, which often, you know, I explain it like if you build up all the muscles around your knees, then your knees have got a choice of where they work from. Whereas if you're very weak, then your poor old knee only has to work on the sore bit. So you try and increase their activity so that it helps them be able to function better without the opioids, and try and impress on them the impact on mood, cognition, balance, sleep, osteoporosis, and infection risk, especially in a pandemic. So, and often I try and reduce their opioids, and usually it doesn't impact their pain greatly. They don't really find a great difference.
Yeah, no, I agree with Dr. Candice there. The elderly is a very tricky scenario because they're so complex. So if you give them more sedating medications, they're more at risk of falls. And that's the issue that we have. We're at the age where we're dealing with osteoporosis, osteoarthritis, and all the others, diabetes and everything else that goes with it. So for most GPs, it's a minefield. I tend to not prescribe opioids unless there's no other modality of pain relief left. I tend to look at other modalities. So it's interesting. You know, we have care plans. We can look at exercise physiologists. We can look at supports. If you've got a good team, you can look at most of our elderly. This stage, you need to assess what their social situation is, who's at home, what their supports are, and especially if you're dealing with multicultural groups. So in our area, we've got a lot of Arabic, Vietnamese, Lebanese, and so you look at all the supports they have to deal with mobility problems. And if you have that in place, that's just as good as giving them oral medications. And then making sure that they have regular preventative activities like to prevent infection, make sure they update with their flu vaccines, COVID vaccinations, and not seeing them unless you really need to in the time of COVID. So those things are really important. So it's a complex question, but I wouldn't be prescribing opiates first line because they're such a complex group. And if they fall and fracture their hip, it's a bigger morbidity that you've got to deal with long term.
Thank you both. I think we're about to run out of time, are we? So,
sorry, Stephen, there's somebody who's asking a question. Is it true that tapentadol is safer? I'd love to hear Candice's point of view, but from my point of view, when people take too much tapentadol, they do have an overdose, and we reverse it with naloxone, which is it is an opioid. Might have those other things in it, but it is an opioid and it has risks of opioid. But I wanted to give Candice a chance because I think it's an important question because we're seeing more tapentadol being prescribed now.
Tapentadol has equal analgesia at half the mu opioid dose. And the mu opioid dose is the one that gives you the respiratory depression and the sedation. So yes, in general, I find it is a safer medication, usually better tolerated with less constipation, cognition, respiratory side effects. Still an opiate, still going to have side effects, still going to be a problem, still not recommended for chronic long-term pain. The immediate release formulation is not on PBS, it's expensive. And so that can become a problem, even though it's safer. Some patients can't afford it. So you might need to go to something less safe, so at least they can get some analgesia when they require it, especially in a perioperative period. So yeah, so while we like it and it's new and the prescribing of tapentadol has gone up and up and up, it's still an opiate. There are still problems.
Thank you. So I think that should bring the evening to a close. I'd just finally like to thank Dr. Olatunga, Joseph Kalegian, Dr. Candice Warman, Dr. Hester Wilson for their input this evening, and I'll hand back to Alex. Thank you.
Thank you to Stephen and all panel members. Thank you to everyone for attending. Do not hesitate to contact us for assistance with SafeScript New South Wales. Thank you.